I was always going to be a doctor, as long as I can remember. I have no other medics in my family, but even from 7 or 8, I think I was always going to go into medicine. I always wanted to do surgery. I like the idea that you physically change something. You intervene and a patient goes from that position to that position and it's an instant thing. So I was at medical school in Sheffield in England. I did all my orthopaedic training in Oxford. So I spent 10 years as a consultant in London. So by the time I finished there, I was head of department at the major trauma centre at St George's in London and doing hip and knee surgery. And then a vacancy came up at the Royal Adelaide Hospital doing pelvic fractures, which is what most of my trauma life is about. Pelvic fracture patients come with lots of other injuries, and so traditionally whoever does the pelvic fractures actually treats most of the complex injuries and typically runs the trauma. So I'm director of the Orthopaedic Trauma Service, and I spend approximately 50% of my time at the Royal Adelaide Hospital, and then the other half of my life is here, where I do some trauma and run the fracture clinic, but I predominantly do hip and knee surgery. I think the things that I do that is a little bit different, I do a lot of hip arthroscopy, which is, there's very few of us that do that in South Australia or even around the world. The other thing that I do that's slightly different is I have a particular interest in partial knee replacement. Oxford's probably one of the best things it's known for in orthopaedics is the Oxford Uni, which is a partial knee replacement. Oxford pioneered partial knee replacement, so that was indoctrinated in my thought processes while I was there. There's two sides to being part of a big clinic like this for the patient's point of view. There's more availability of appointments, and so if they can't see this surgeon, well, they may be able to see that one. But also within the clinic, there's lots of discussion that goes on between the different groups of surgeons. Before now, we've even brought the patient in and had 3, 4, 5 surgeons look at them and say, as a group, this is what we think we should do. So there's a huge benefit to that within a specialty. But also across the group. So for instance, the fracture clinic, if someone comes here, it doesn't matter what part of them is injured. If the surgeon seeing them on the day doesn't cover that, we've got 20, 24 other people that will be available at some point who cover everything. And so between us, you cover the whole skeleton. And so there's that element of actually, it doesn't matter what it is, we can deal with it. Actually being part of the big group is really important. Actually, it's fun and it's rewarding, and you get patients who are significantly damaged, and you spend a long time with them. We often follow them for a year or 2, all the way through their recovery, and then at the end it's quite nice. Sometimes you see them 3, 4, 5 months down the line for the first time you see them walk, because you meet them when they're lying in a bed or they're brought in by the ambulance or whatever. And so it's quite rewarding to follow them through that journey, and suddenly in they walk with a smile on their face.